great. Okay, good morning, everyone. Happy Friday. We made it. And I want to say this has been an awesome 12th annual International Conference on Stigma at Howard University. I hope you enjoyed it. If you stayed with us every day or part of the days, thank you. And I hope that you learned as much as I did and also unlearned anything that you previously thought was correct. And so today will be a shorter day ending at 1 p.m. However, don't underestimate the content for the day. We're going to start off with a friend of mine, Dr. Froni Jackson. It's so good to see her. She is a certified mental health first aid facilitator and the executive director of Walk Ward 5 Health Coalition. She is also an assistant professor at the University of District of Columbia, one of my favorite schools here locally. And this morning she is presenting a training entitled Becoming a Mental Health First Aider to Reduce Stigma. Following her presentation, we will have a short break. And let's see, my screen froze, everyone, so I'm gonna just guess what we're gonna do. No, I'm just kidding. Following her presentation, we'll have a short break at noon with a video session you definitely don't want to miss. And after that, we will wrap up with a short closing from our awesome Dr. Rana and Patty Houston. And so with all that said, let's bring to the screen stage Dr. Froni Jackson. Yay.
Thank you, Lisa. It is such an honor to be here. I am really excited about presenting this material today. I hope everyone can see my screen. I am sharing, and today's session is entitled Becoming a Mental Health First Aider to Reduce Stigma. And I want to say I am presenting this, but I am presenting this in a fashion that I want to be more of a conversation and a dialogue. I want it to be interactive. So I'm going to have some questions for the participants, the attendees, as we move along. And so it can be more interesting. It'll be informative and interactive and interesting. Those are my eyes for this session: informative, interesting, and interactive. So with that in mind, let's get going. Now, I'm hoping that, I believe that you all can see my screen, and this is my welcome to everyone. Thank you for joining me this morning. I want to do sort of an icebreaker. So we have a chat, I believe, or we have a question and answer. So I can't see you all. You can see me, I'm sure, in a little box. And you can see my, I can't see you, slides. But I want in our question and answers or chat, if you would just put your name there and then tell me if you have ever heard of mental health first aid before. If you haven't, simply say no, which is a good thing because you helped me to accomplish one of my goals for today, which is to bring awareness to this fabulous evidence-based program. And if you have, just kind of give me some content around how you've heard about it. Have you attended a class? Have you, I see them coming in now. Okay. Okay, oh yeah, I love it. Okay. Okay, kind of half and half. Awesome, awesome. Okay, very good. I see some, good. We're starting off on the right track. We are starting off being interactive. I see you putting the responses in the chat box. Thank you very much. Okay, so let me give folks another couple of minutes or so just to, again, type your name in the chat box so I at least can know that there's some folks out there with me. It's so hard for facilitators to do these Zoom and these virtual trainings because you're used to interacting with other folks. And when you're on this computer and you're looking at a box and you're like, oh my gosh, am I just talking to this screen? Is there somebody there? So thank you all for chiming into the chat and letting me know that you're there, and actually let me know if you've heard of mental health first aid or not. It looks like about a fourth of you so far have heard of it. A couple of folks have actually taken the training. I have a a South Carolinian who's taking the training, Kurt, and I also had a New Yorker who's been certified in mental health first aid. So that is really good to know. And Christopher Jackson has been certified as well. And that was Torian, if I think I said that right, Baskerville. Has been certified as well. So very good. This is good. So now we're gonna, it's good. It's good to know that we are actually bringing awareness to it. I'm taking the training that's, Takesha's taking the training more than once in Maryland. Very good. Yeah, Maryland is a big mental health first aid state. Lots of trainings happening in Maryland. Yes, I pronounce it. Oh, good. Thank you. Thank you. I hate butchering people's names, Tori, and so thank you so much for letting me know I was on the right track there. With a name like Frony, I get butchered quite a bit. So I am really conscious of pronouncing people's names correctly. Okay, very good, very good. So as I said, it looks like about a fourth of you are familiar with it. And then we're just gonna, Siobhan, okay, just taking it in DC. Awesome. Okay, very good. So thank you for the icebreaker. So you know me, I know your names, and the youth one as well. Yeah, so there's mental health first aid for adults, for youth, for adolescents. There's mental health first aid for specific target populations like law enforcement, medical, emergency medical personnel. There's mental health first aid for higher ed. So there are really lots of different specialties under mental health first aid, which is really, really good because it can kind of take the content and hone it into the specific area in where these first responders are working. So that's really good to know. All right, excellent. I'm gonna close the chat. Okay, that was my icebreaker. So I'm feeling a little bit warm right now as we speak. I'm gonna move to, okay, I'm gonna try to advance. There we go. Okay, so what you can expect today is I will talk to you about mental health first aid. I'm going to focus on specific parts of it and how we can use that in our fight against stigma. So our goal is to bring awareness of mental health first aid with a focus on associated stigmas of mental illnesses and disorders and hope for recovery. And we definitely we'll be talking about that hope for recovery because we don't want to combat that stigma. We have to let people know that mental health per se is not something that is everlasting and that there can be recovery from it. And I think that helps us to move beyond stigmas when we talk about being able to get over, recover, recuperate from the illness. So my objectives and how we're going to accomplish that goal today is I'm going to explain mental health and its challenges on adult well-being. We're going to describe the correlation between how stigma impacts persons living with a mental illness or disorder. We're going to describe what is mental health first aid, and we're going to list the steps of the mental health first aid action plan. So those are the things that we are going to do today, and I will go back periodically to that to make sure that I am staying on track. So our overview based on our goals and objectives is today I'll be presenting what is mental health problems in the United States, stigma and mental health, what is mental health first aid, mental health first aid action plan. Those are the things that we are going to discuss. Those 5 things today will be the things that we will discuss. So let's just jump right in there. Okay, so remember I said very interactive, interesting, and informative. So here again, I'm going to ask you all to participate. So mental health, right? We hear that term tossed around, but it means different things to different people. So I want you to put in the chat box, when you hear the word or the term mental health, what immediately comes to mind? And don't be shy. Think about when you are out and about and someone, you may hear folks talking about mental health, or you may see something in the news or the media about mental health. I mean, those kind of things have shaped our thinking, our mindset, how we approach this subject matter. So I want you to put in the chat what comes to mind immediately. I mean, I can tell you I've kind of grown from when I first thought about mental health way back when and to how I think about it now. I've had this revelation. So I want you just to put in mind in the chat, when you hear the words mental health, immediately what comes to mind? What comes to mind? Don't be shy. I want to hear all the comments. All right, I see. Ooh, let me go see if I can go back up. Just trainings. Okay, so I see here changes in emotional state, its regulation, self-concept of reality. Oh, these are great. Yeah. Oh, I love that, Takesha. Fear, misunderstood, and not normal. Absolutely. Crazy, absolutely. That's the word we hear all the time. Crazy, cray, cray. Absolutely. Misunderstood. Hey, come on, everybody. Just put what comes to mind when you hear those words. An ability to cope with normal stresses of life. Very good. Yep. Yep. Individuals emotionally respond to life changes. Violence. Yes. Yes. Let's see what we have. So I want to the balance between thoughts, emotions, and behaviors. Absolutely. Writing some of these down now. Fear, violent. Okay. I got some more. I got 3 more down here I haven't gotten to yet. Instability, homeless. Absolutely. Oh, I've got 2 more. Keep them coming. I love it. Mental health for me is a focus on the importance of taking care of one's mental state. Yep. Kelvin. Emotional well-being. Thank you, Patty. Stability. Okay. All right. Very good. Now, I want to be able to racial bias. Absolutely. These are great. Great, great, great. I'm hoping we can keep this chat going, be able to get back to the chat. Okay. All right. Very good. So thank you so much. So those are all words. Oh, got another one. A person's mental state, mental, emotional, spiritual, and physical well-being. Yep. Thank you. Great. Okay, so we got a lot of things for different people. A lot of different things come to mind when you hear those words, mental health. Some of them, and we're going to go into why I did this exercise in just a moment. Okay, so what is mental health? So we just talked about the terms of the thoughts that come in our minds when we hear those words, mental health. But here is the official definitions of mental health based on the World Health Organization and the Centers for Disease Control and Prevention. Now, I'm certain that you all are muted, so I will read these definitions quickly. I normally don't read my slides, but we have a large group and you're probably muted. It might be easier for me just to do that, and you can read along with me. The World Health Organization, WHO, conceptualized mental health as a state of well-being. We heard a lot of that in the exercise we just did, in which the individual realizes his or her own abilities, can cope with the normal stressors of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So that is how the World Health Organization, WHO, defines mental health. So the World Health Organization is, they the population they target, they create policies and programs, do research that's based on the entire world, the whole globe, where the Centers for Disease Control and Prevention normally or usually focuses on the US and then the areas outside of the US that the US has some specific interest in. So the Centers for Disease Control and Prevention's definition of mental health is it's an important part of overall health and well-being. Again, those terms that we've heard. Mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make healthy choices. Mental health is important at every stage of life, from childhood, adolescence, and through adulthood. And that's why we have mental health first aid for all of those populations, youth, adolescents, and adults. So we can see a lot of what we see here in these two definitions are very similar to a lot of the things that you all put in the chat box that you said comes to mind when you hear those two words, mental health. Very good. All right, so we are moving right along. All right. Oh, I want to do breakout groups, and I just didn't think about that in advance. Can we do breakout groups? Can we divide up our participants into breakout groups? Is it too late to do that? No, we can't. Okay, no problem, no problem. So this is what we're going to do. All right. I want each of the participants in to look at my screen here. We're talking about mental health problems in the United States. Mental health is quite common in the United States. It's way more commonplace than most people think. And that's because it's been sort of this taboo topic that no one really wants to address or focus on. I'll talk about. It's scary, it's the unknown, based on some of the words that you all even put in the chat box during that last exercise where we talked about violent and crazy and fear and misunderstood instability. Those are things that are very pleasant that people don't deal with, so we don't keep those in the forefront all the time. But mental health is common. Mental health problems are common amongst the United States. This diagram or this chart right here, on the left-hand side, it describes very specific types of mental disorders: anxiety disorder, major depressive disorder, substance use disorder, bipolar disorder, eating disorder, schizophrenia. And on the right-hand column, it basically is saying what percentage, it is asking for a percentage. And what I want you to do is think about this and put in the chat box. What percentage of adults in any given year do you believe would experience anxiety disorder? Or what, for each of these mental disorders, in that column on the right-hand side, I want you to give me a percentage of the number of adults, or the percentage of adults, and this is in the United States, just in any given year, would experience one of these mental disorders. So I want you to put it in the chat, and we're going to talk about it. I'm going to show you the answers, and we're going to talk about it. Okay, we got 2 folks going, 3. Okay, it's coming. And 4. I'll give you guys a little more time. Okay. That's okay. Okay, so you're all giving me percentages. Are you giving me percentages for all of these together, or are you giving me percentages for specifically for anxiety disorder? Or okay, so here we go. All righty. Okay, I see it now. So we got 80. Wow. 85, 75, 80, 65, and 79. Okay. Anxiety, that's 70. 90, 85, 80. Major depressive, 75. Okay, interesting. It's still coming. Okay. Oh, I see some more folks have popped on. Welcome, 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 and thank you for chiming in. 60. Okay. Okay, I'll give folks another minute, and I see more substance abuse 60. Wow. Okay. So what we're doing for those who just hopped on is we're looking at these mental disorders on the left-hand side of the chart, and we're saying we're given a percentage as to how many adults in the US in any given year experience that disorder, because we are actually showing here that the purpose of this is to show that mental health problems in the US are very common. Okay, 80, 65, 75. Okay. All right, very good. Okay, awesome. So thank you, 7. Now I want you to answer this bottom question. If you have not, fill the chart for this bottom question. Percentage of people with a mental illness that uses mental health services in any given year. So you've told me that all of these percentages of people have had experienced these mental disorders. Now I want you to tell me, out of those individuals who, 15% on eating, wow. Out of those individuals, those percentages, how many of them have actually sought and used mental health services in any given year? Okay, Kirk, you got around 25%. I got Jody got 25, Jacqueline got 30. Okay, 30, 20, Patty got 40. All right. Okay, anybody else want to put in the percentage of people with a mental illness that's used mental health services in any given year? 40, 43. 30. 30, okay. Awesome. 30. I placed before 45, okay. 40. Okay, I just want to make sure I don't move before everybody's had an opportunity to put in their answers. All right, it's kind of quiet. You know how when you're popping popcorn and you don't hear that pop, 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 it's time to pull a bag out the microwave. So I think it's time to pull a bag out the microwave. Well, as soon as I said that, somebody else chimed in. Okay, Rhonda, you said 50%. All right, now I am going to show you the answers or show you the results. Okay, so in the United States, in any given year, adults that experience anxiety disorder is about 18%. So 18% of the adults in the US in any given year experience anxiety disorders. Major depressive disorders, 6% of adults in the US experience those in a year, those disorders. Substance use disorders, 8% of US adults experience substance use disorders. Bipolar disorders, about 3%, 2.8. Eating disorders, 5 to 10%, and schizophrenia, less than 1%. And then out of these percentages of adults who experience mental disorders, 41% of them actually use mental health services. So less than half of them are getting mental health, just help with their mental disorders. And these are high percentages, because we know in any population, if more than 1% of your population pretty much has a disorder that's an epidemic, right? So this is commonplace. We have 18% of adults experiencing anxiety disorder in any given year. That's an epidemic. Same thing for major depressive disorder, substance use disorder, bipolar disorder. And it's really interesting too, and I just want to put this in here now. Oftentimes, I even ask you this question. When you think, when we were talking about, what comes to mind when you hear the terms or see the terms or the words mental health, some of the disorders that come to mind immediately are bipolar, schizophrenia. A lot of times those are the ones that people refer to. But if you see or you notice on this slide, it's really fewer people in any given year are experiencing the bipolar or the schizophrenia. It's the most common mental illnesses or disorders are with the anxiety and the major depressive disorders, and then substance use. But for some reason, we will also, the media depicts people with bipolar. In the movies, we see a lot of the entertainment area, we see a lot of mental illnesses depicted, and what they're trying to show is schizophrenia or other kind of disorders that are more psychotic related. But we see anxiety and major depressive very, very common. 18% of adults are experiencing that in a given year, and not just feeling a little anxious, but actually we're going to talk about what it means to actually have an illness or disorder with those, with that. What those criteria are to be actually diagnosed with these things as being a disorder. So thank you so much for sharing, dialoguing, interacting with me on how common these mental illnesses are in the US. I'm going to go to the next slide. I got it. Okay, so a mental disorder or mental illness, it is a diagnosable illness, right? And it can be any of these things that's going on in this person's head here: anxiety, phobia, stress, PTSD, depression, panic, shame, grief, all of these things, right? But people feel these ways a lot of times, right? And what we got in the chat box. Are those percentages based on those who sought services? No, thank you for asking. No, those percentages were, so the question in the chat box, were those percentages based on those who sought services? No, those percentages were not necessarily based on individuals who sought services. Those were, a survey was done and they asked the question if you've experienced this, or if you had a diagnosis of this particular mental illness. It and then later, after the sort of towards the end of the survey, it said, now did you seek treatment? And that's how we got that only 41% of those individuals who said that they were experiencing or were diagnosed with those illnesses actually received treatment. So no, the percentages are based on everybody who reported that they experienced those disorders or were diagnosed with those disorders, not the ones that were treated for those disorders. And we see that when that question about the treatment came in, only 41% of the individuals said yes, they received treatment. That answer your question, Derek? Okay, I'm gonna keep moving forward. I'll just keep checking the chat. Okay, so again, so what I was saying was people, they feel these things, we have these feelings, right? Sometimes we're sad or we're down or we're blue. We hear those terms. I'm surprised we didn't get any of those terms when we early on, when we talked about, what comes to mind when you hear the words mental health. But, some people can be a little sad, down, feeling anxious, having a whole lot, feeling overwhelmed, right? And those things, they're kind of psychological, right? But they're not necessarily a diagnosis of a mental illness or mental disorder until they meet certain criteria. And those criteria that we're looking for is if those feelings or those emotions or those experiences that that person is having affects their thinking, emotional state, and behavior. And we had a lot of that in early on when y'all answered the questions about what comes to mind. So if the feeling that the person is having of stress or overwhelming or being sad or down or really anxious and uptight, if those feelings are affecting the person's thinking, emotional state, and behavior, then that's going to lead towards a diagnosis of it being a mental illness or mental disorder. If it lasts for a certain amount of time, because we feel that way, all of us feel these ways at some point in time, but then, you know, the next day might be a little bit better, right? It's better in the morning. We've been able to think through it and we're able to cope with it and deal with it, and we're not experiencing that. So it was just what was going on with us at that moment, not necessarily illness or disorder, unless it starts to affect our thinking, emotional state, and behavior. If it stays around for more than 2 weeks, usually with depression. But then also, if those things that we're experiencing, feeling, disrupts our ability to work, to carry out our daily activities, and to engage in satisfying relationships, if that overwhelmingness, if that sadness is now affecting our thinking, emotional state, and behavior, and it's to the point that we cannot do our work, we cannot carry out, so holding down a job is going to be difficult. We're not focusing at work because of these things. Carrying out our daily activities, that can even be cooking or hygiene type of activities or things that we do on a daily basis. If we can't do those because of that sadness or that anxiousness, then it's a mental illness or mental disorder. And if it's interfering with us having satisfying relationships, that can be a romantic relationship, it can be maternal, paternal, it can be a family relationship. But if those things that are being experienced are disrupting the person's ability to do these things, now that is just not simply, I'm just simply down a day, I need a break, I'm overwhelmed. No, now that is a disorder or illness that needs to be addressed. So the impact of all of that, right? So if you are dealing and you're experiencing all of those feelings, it's going to impact you. So we already said, if it's to the point where you can't do your work, your daily activities, or have a relationship, then it's a mental illness, right? But I want to point out here that those, I got one more to do. Nope. Okay. It is those illnesses, those disorders are disabling, right? They are stopping us from being able to do work, to carry out our daily activities, to engage in satisfying relationships. And sometimes those illnesses and disorders are more disabling than physical illnesses that we have. So, and I want to point this out too, because you know, mental illnesses and whole psychological, the thing that's going on in your mind has not been looked at for a long period of time, especially in certain communities, as a disability, right? But it is a disability. It stops you from doing certain things, and it is as disabling as physical ailments that we go to the doctor for. Remember, we said a couple slides back, only 41% of individuals who are experiencing those disorders and illnesses are getting help, are seeking help, are in treatment, but they should be in treatment. If you look at these last two bullets, mental illnesses can be more disabling than many physical illnesses. For example, a person who is dealing with depression has a similar or is having the same impact on them as a person who is dealing with multiple sclerosis, severe asthma, or chronic hepatitis B. There's an impact. There's an impact index on how disabling an illness is. And on that scale, the same impact index is given to multiple sclerosis, severe asthma, and chronic hepatitis B is the same number that is given to someone dealing with moderate, not even major, but moderate depression. That illness is stopping the person from being able to do things just as if somebody who has severe asthma, chronic hepatitis B, or multiple sclerosis. And think about that, severe asthma, you cannot breathe, right? You are having difficulty breathing. That is majorly serious. And so you're going to seek treatment for that. But somebody who is moderately depressed, that illness and disorder can stop them, disable them from doing things at the same level as somebody who's having difficulty breathing. So that person needs to seek treatment, and we need to recognize that. And the same thing for severe, think about severe depression. If somebody is experiencing severe depression, that is as disabling as somebody who is a quadriplegic. And think about that. You cannot use your limbs, basically. The same, that is what somebody who is experiencing severe depression is experiencing as well. Absolutely. I'm reading the chat now. From Russell, absolutely. Many of my patients become literally paralyzed by their depression. Exactly. Thank you, Russell, so much for saying that, because that is exactly what we're trying to say here. And that's where in the earlier, when you guys were chiming in for me, there's a lot of misunderstood was said that comes to mind when people think about mental health, and people don't understand this, but the mental illnesses, mental disorders are as disabling and disruptive to a person's life as physical disorders, and we have to recognize that and stop sweeping it underneath the carpet. Thank you, Russell. All right, so another question for you all. Told y'all interactive, it's just me talking, but I'm pulling it out of you all in the chat box. So thank you for participating. What are the words that come to mind when you hear the term stigma? We're gonna move to, okay, I see chat. So I'm already coming in the chat. When you hear stigma, because that's what this conference is all about, stigma, right? Stigma. What comes to mind? Hear that word, stigma. I got one person in the chat so far. Let's see what we got. This is where many stigmas are placed on people who do not understand co-occurring disorders. Yeah, co-occurring disorders. Exactly right, Rhonda. Yep. Something that makes me uncomfortable. Okay, so stigma is something that makes you uncomfortable. Absolutely. Any more? Bad, do this. Okay, bad stereotyping. Yeah. But yeah, pointing you out as being different. Exactly. Discrimination. Absolutely. Disrespect, prejudice. Yes. I think I missed some. I'm gonna try to scroll up a little bit. Uneasy to talk about. Yeah. Isolation. Yeah. Fear. Absolutely. Out as being different. Yeah. Yeah. Oh, got some more. 4 more. I didn't get to. Let me go down some. Uneducated. Stigma by association. Absolutely. Limitations. Yep. Judgment of a person's own opinions or negative comments. Absolutely. Absolutely. All these things come to mind. Negative labels assigned due to a specific attribute. Shame. Yep. I'll give you guys a little more time. See if anybody else. Okay. Thinking and judgment. Yep. Not conducive to the event or the person. Yep. Don't understand it. Don't want to deal with it. That's correct. Absolutely. Oppression. Yeah. Trauma. All righty. Okay, good. Thank you, thank you, thank you, thank you. I'm gonna try to keep these chats because it's gonna help. Secret, yeah. Yeah. We keep it a secret. It's a taboo to talk about it. Absolutely. I love these. Great. Okay, so as I did before, I got your thoughts on what these terms were. And then I went to the experts, not like you all aren't. But at least I went to the literature then. So stigma and mental health. So stigma is when someone views you in a negative way because you have a distinguishing characteristic or personal trait that's thought to be or actually is a disadvantage, a negative stereotype. Sounds like a lot of what was said in the chat just above. Cut off from religious services. Okay, thank you, Jacqueline. Yep. So in this definition in the literature, it definitely matches a lot of what you all said in the chat box. Unfortunately, these negative attitudes and beliefs toward people who have mental health conditions are common. We know that, right? When people have mental health issues and disorders, they are almost always immediately looked at or viewed as negative. And we can see that from that earlier when you all put in what you thought about mental health. What comes to your mind when you think about mental health? So we had some of those terms that you all said, or something that came to mind: violent, crazy, fear, misunderstood. All of those things are negative. People think of these, associate these terms with the person who's experiencing a mental health issue, and all of that is negative. That's going to start to, the person's going to be stereotyped and going to be stigmatized because they are being viewed as negative. They're being viewed as violent. They're being viewed as crazy. They're being viewed, they're not understood, and people fear them. Exactly. And again, as you all said in the chat, stigma can lead to discrimination. All of that, all of those things can lead to the person being discriminated against on so many levels, right? And I think this one, we'll talk about that a little bit. Okay. So the harmful effects. Yep, this is what I want. Okay, so that stigma around mental health, it has very harmful negative effects on the person who's experiencing the illness, right? Reluctance to seek help or treatment. We saw that in the data that I presented earlier. Only 41% of those individuals who were experiencing mental illnesses and mental disorders sought out help. And one of the main reasons why they don't seek out help is because the stigma that they feel like it's going to be attached to them when they actually go to somebody to tell them what they're feeling and what they're experiencing. Right? The lack of understanding by family and friends, coworkers, and others. Right? That's that whole being misunderstood. That is an impact. That is definitely an effect, an impact of stigma on a person who's experiencing a mental health issue or disorder. Fewer opportunities at work, school, or social activities, or trouble finding housing. And a lot of that actually plays right into the discrimination piece. Those opportunities are fewer really because they're being discriminated against. They're not getting the chance for employment, for school, to participate in social activities. They're not, people are discriminated, who are experiencing mental illnesses and disorders are actually denied housing in some instances. This one, I like to talk about the bullying, physical violence, or harassment. One of the things that we said earlier when we talked about mental illness, what comes to mind, or mental health, what comes to mind, somebody said violence. And oftentimes that violence is, people think that the person that's experiencing a mental illness or the mental disorder is the one who is violent. And that's not the case. So most of the time, that is not the situation. Most of the time, that person who's experiencing a mental illness or the mental disorder is a victim of violence. They are being bullied or they are being harassed. Oftentimes, our health insurance will not cover mental illnesses. I want to touch on that just briefly, but earlier we talked about on one of the slides, it said, where was it? Can't see it, but it was association. It was saying that the stigma is you can be associated. If you're associated with the mental health or mental illness, you can experience stigma because of association. So I used to work an agency that provided services to African American women who were HIV positive and their families, and just as a public health professional in that organization, I would be stigmatized because of my clients that I was working for. Like someone else could go in and was trying to get services for somebody who had cancer. Services easy, they could get them. When I went in to get services, different agencies to get services for my clients who were experiencing, as somebody said earlier, co-occurring illnesses, HIV and mental illnesses, it was really hard to get anybody help. They didn't want to touch that. So not those people. No, awful, right? And the insurance that they had, and that's how I got on my soapbox here, I'm sorry, because the health insurance that they had did not adequately cover the mental illness treatment. So the insurance didn't cover it. So the providers really weren't trying to see the clients because they didn't feel like they were going to get paid. So that is just a horrible circle, and that we have providers, insurance companies, medical facilities that aren't treating individuals with mental illnesses because of it's a vicious circle there. I'm gonna get off that soapbox and I'm gonna go to the last bullet. The belief that you'll never succeed or obtain, you'll never succeed at certain challenges that you can't improve your situation. Okay, so that's what I said in our objective, one of the things we wanted to talk about was recovery. The person who is experiencing mental illness, mental disorder, they don't have to stay there. There's treatment and there's recovery. So the stigma can come from within sometimes because a person may believe that they cannot get over this challenge and they won't be able to succeed. So part of the treatment has to be able to explain, discuss, make certain that the person who's experiencing the mental health, mental disorder, and we'll talk about this in the action plan a little bit later, is how they can do things that are not self-stigmatizing to them. Any questions or comments about this slide or any of the harmful effects of stigma around mental health? Anybody want to chime in, add anything to the chat here? Good. All right. Okay. Nothing. All right. Well, do this for me. If you don't want to do that chiming in, I want you to give me a thumbs up if you're still with me. I can't see you because I'm sharing my slides. I just want to make sure I still got you. I haven't lost you. I'm with you. Thank you, Rhonda. All right. All right, Dawn, you there? Thumbs up. Okay, all right. I just want to make sure, I told y'all my facilitation style is a little bit different. I don't like talking to boxes. I would love for us to all have been in the same room and having this conversation. And I know you're with me for sure, but thank you so much for letting me know that you are with me. I appreciate it. Thumbs up. Okay, awesome. Thank you, thank you, thank you, thank you. Thumbs up, perfect. All right. Oh, got another one. Let's see what we got. I'm here, Jody. Okay, perfect. And can you speak briefly on the percentage of patients who are aware of their mental health limitations? Okay. So, hey, Russell, thanks for that question. I don't know the percentage, the official percentage of the patients who are aware of their mental health limitations, but in my experience and the clients that I worked with in the past, by the time that they come to you, they know. And we're going to talk about, Russell, you're making me scroll ahead to something I don't want to talk about yet. But I'm going to touch on that a little bit later. But this is it. When something is different, and I hear this all the time, I don't feel like myself. The clients will come, I don't feel like myself. No, and that's when they know, that they're experiencing some kind of mental health, something. They don't know what it is. They can't diagnose it, because it's not something that we commonly talk about. but they know something is different. They know something is not right. So that is happening. We're going to talk about and sometimes they don't know. Some people don't know. And everybody knows about the stages of change, right? And that first stage usually is pre-contemplation. So that's when a person really don't know what's going on, but the other people around them might notice something, it may say something. And then that may take the person from that pre-contemplation stage to start contemplating that, hey, something might be going on here actually. So some patients don't know, but most of them do know that something is different with them. But then also when we're talking about, remember, because we said that some parts of some signs and symptoms of mental illness and mental disorders, that the person is not in touch with reality, right? So if they're not in touch with reality, they may not know, because they're so far along, they've not had any treatment, and it's gone on for such a time that now they're not in touch with reality. So they may not know what's happening. So some people do know, and some people and other folks don't, and for many reasons. Please know that me this hear you. Your comment exactly what I was looking for. Thank you for the questions. I love the interaction, so thank you. Okay, very good. Okay, so when we talk about coping with stigma, here are some ways that an individual can cope with the stigma, right? Get treatment, right? Just that simple. Y'all know I'm being sarcastic at this point, right? Because getting treatment is not always just that simple, but treatment is a way to deal with stigma. Don't let stigma create self-doubt and shame. That was one of the things we just talked about, creating the stigma yourself. Individuals will create their own stigma. Isolating yourself. Don't isolate. Thinking, so the isolation can come from not wanting anybody to see or know what you're experiencing, right? Or the mental illness itself can just make you feel like you don't want to be around other people, because that not being in touch with reality, maybe being fearful that other people are hurting you, or that the voices in your conscious mind are saying to you, keep away from other people. That's usually when people are experiencing some type of psychosis. Equating yourself with your illness. And we're going to talk about that a little bit too. It's an illness, it's not the person. And if the person stops equating themselves with the illness and just knowing that that's something that they're experiencing, that can help reduce some of the stigma, some of the self-stigma. And when we equate the illness to the person and not just saying that the person is experiencing something, that causes stigma on the other person. So we want to not do that. 11:20, I'm just checking my time. Support groups are very helpful. A helpful way to reduce stigma. Getting help at school. Most schools have mental health professionals, and being an advocate, attending the international conference on stigma at Howard, and being an advocate and speaking out against stigma, not just with mental health, but stigma, all kind of stigma. I've had to speak out on stigma against individuals living with HIV and AIDS, right? So it's all kind of stigma that people experience, but these are some things that can happen, that can be done to help cope with stigma and stop other folks from stigmatizing individuals. Any questions, any thoughts, or any comments on some other ways individuals can cope with stigma? Either the person who's dealing with the mental illness, how they can cope, or a person who is trying to help an individual with mental illness, how they can help eliminate some of the stigma. Anybody want to add anything? Okay, don't look like it. I'll go to the next slide then. Okay, so that was how we can deal with some of it. How are we going to combat this thing? How can we just get rid of it? Let's combat stigma. How can we get rid of it? All right, so as I was saying a couple of minutes ago, we don't want to equate the person to their illness, right? So one thing we can do is use people first language, where we prioritize the person over their illness, disability, or condition. And this is not just for mental health, this is for any illness, right? So but for mental health, when it comes to discussing mental illnesses or declining mental well-being in everyday life, instead of emphasizing a person's condition, use a more appropriate people first alternative. And here's some examples, right? So if we say the person suffers from depression, that's stigmatizing. And it's not as bad as some other things that I've heard, but what's more respectful, the way to make this more people first, or put this in more people first language, it says this person lives with or is experiencing depression, right? And here it says this person suffers from depression. Normally what we hear is this person is depressed. So saying this person equals depression. No, that's not it. To be respectful, to be more people first, that person is living with or they are experiencing depression. They are not depression. Okay, the person committed suicide. Again, that is one of those statements that we don't use anymore, you know, politically correct. The person died by suicide. Committed suicide kind of is blaming the person. We want to be person first, so the person died by suicide. When we say things like that drives me crazy, insane, or nuts, that's saying that it's a situation that you are not happy with. It's not pleasant. It's a negative situation. And when we use these terms, insane, crazy, nuts, which is just some of the same terms that we use for people who are experiencing mental illnesses, it's stigmatizing. It's more respectful to say that bothers me, it annoys me, it frustrates me. So again, people first, person first. Okay, this term we know too, all too well. We hear way too much. The person is or was a junkie, an addict, junkie addict, very negative, very stigmatizing, very horrible terms, right? Horrible words. A better, more respectful way to express that is the person lives with a substance use disorder or the person is in recovery. And we can see just by saying these things, how these respectful statements here can help to reduce some of the stigma. Some of these are way less negative than if we say these things on the left side of the chart over here. Right. Any comments or questions about people first language? Any other ones? And I just really did this one because it talked about substance use and mental illnesses, mental illness. But if you have another one that's like something that's stigmatized and how you could say it better, put it in the chat box so we can hear. I'm gonna give one that's not here. That in a class recently I was teaching, one of the participants said, I said something about a person was homeless, and then the participant in the class said, no, the person isn't homeless, the person is housing challenged. And I said, oh, thank you. That actually does sound a whole lot better. So have you all heard of anything, any terms that we're saying differently now, that terms that we would say in the past that sound more stigmatizing, and now there is a more respectful, more politically correct way to say it? Oh, getting some, okay. Okay, so here, yeah. Person living with HIV, I try my best not to use stigmatizing language for any person, anything, but sometimes I just may not know. Yeah, and sometimes, you know, we don't know, and we just have to say, I'm not trying to be offensive, and we recognize our ignorance, that we don't know, and then that can go a long way too, just to let people know that we are trying to learn, and we want to say and do the right thing. We don't want to say anything that's negative or stigmatizing. Houseless, okay. Jody said houseless. Right. Thank you, these are great. Like these are really good. Like I'm saying, in that course I had, when a young lady said housing challenge, you know, I learn when I present. So these are really helpful. Thank you as well. All righty. Making sure I'm moving along. So stay on track. In here. Let's go to the, oh, not addict, but substance use disorder. Exactly. Not not addict, but substance use disorder. Exactly. Like at the so can you all still see my slides? I want to make sure of that. The slide says stigma and mental health. What can we do to combat? Okay, good. I just want to make sure. Okay, yeah. So so not addict, but substance use disorder. Right. So like the last one down here, the person is or was an addict or a junkie. Instead of saying that, we would say the person lives with a substance use disorder or the person is in recovery. Exactly. Okay, very good. All right. So let's now move to, I got 20 minutes and I got 2 more things I want to talk to you about. Okay, mental health first aid. So what is mental health first aid? So mental health first aid is the help offered to a person developing a mental health problem or experiencing a mental health crisis. The first aid is given until appropriate treatment and support are received or until the crisis is resolved. And let me talk about this a little bit. So remember, we talked about how mental health illnesses and disorders are as disabling as physical illnesses, right? So the mental health first aid, you can equate this to CPR and first aid. So when we talk about CPR and first aid, we are talking about the person, someone has either fallen down and gone unconscious, right? And we go to help that person. And we check to see if they're breathing. If they're not breathing, then we start to breathe for them, right? That's the CPR, right? Breathing. If we're checking their pulse, we don't feel the heart beating, and we start to push on their chest to make the heartbeat, right? Let me see how am I doing. I cannot remember that. Oh, I'm Rhonda. You ahead of me. I'm getting there, girl. I'm getting there. It's algae, but we're gonna be talking about that in just a second. Give me a couple more slides. We're gonna be talking about that in a second. You got it, Rhonda, though. Awesome. Thank you. So that's the physical thing, right? CPR first aid. There's an acronym for that, right? It's like ABCs. It's like the airway. We make sure the airway's open, make sure they're breathing, and then we start to do our compressions. And that's what a person who's having a physical ailment is a physical emergency or a physical crisis. We go in to start doing these things until the appropriate treatment or support can come. So with mental health first aid, there's some things that we do for a person who's in a mental health crisis. There's some things that we do with them until we can get them to the appropriate person for treatment, or we can get them the support to them. So that's kind of mental health first aid. It's the same as CPR and first aid, but instead of focusing on a physical ailment, it is what we do in the gap with someone who's experiencing a psychological and mental ailment until we can get them to help. We're not the therapist, we're not the counselor, we're not treating them. We are helping them to hold on until they can get to appropriate treatment. So that's what mental health first aid is all about. Now I want to okay. So, and we do that too because the person is worthy, and we know we can get them through that. They can get to recovery. So recovery is a process in which people are able to live, work, and learn and participate fully in their communities, right? So we want to get people from mental illnesses and mental disorders to recovery. And we have to start, we start with this mental health first aid. For some, this is the ability to live a fulfilling and productive life despite disabilities, right? So remember, the mental illness is not the end all. That can be recovery. They can have a productive life. They can. For others, recovery implies a reduction or complete remission of symptoms. So we want the symptoms that are associated with the mental illness. It can be it can be the isolation. It can be the voices. I mean, it can be all of those negative things. We want those to be reduced or want them to be removed altogether. So that's about recovery. And that's another reason why we do mental health first aid. So in mental health first aid, we talk about the spectrum. We have a spectrum of mental health interventions. Just like most people who work in HIV and AIDS, there was that spectrum, right? We had the spectrum that we were getting people to be, undetected, right? Undetectable. And for mental health, we want to get them to a state of recovery. So this spectrum, let me explain this chart right here. So this bottom thick line down here, this is talking about the where the person is with their mental health. So we hope that most people are well. And then things happen in life, and then they can start to become unwell mentally and psychologically. They're becoming that. And then after not being treated, nothing happening, then they are actually unwell. They are actually experiencing depression. They're actually experiencing anxiety. They're actually experiencing schizophrenia. And then when they get treatment, they can start to recover, right? Those symptoms can start to be reduced or go away. And so that's the person, right? And the interventions that we use for the person, depending on where they are in this spectrum, is if people are well, individuals are well, we do prevention, right? Prevention can be things like meditation and breathing and time management, not taking on too much, to stay well, right? Knowing when to say no. But if someone starts to become unwell, we want to do some early intervention, right? We want to do some things, get them into some programs, maybe some support groups, maybe to help them to turn around some of those negative things that are creeping up. If the person continues to move towards experiencing a mental health disorder or illness, and they are unwell, then we need to move them into treatment. And we're going to talk about who would do treatment. And treatment, we hope it will result in recovering. So this green box that you see here, that's where mental health first aid can come in. It can come in when the person is starting to become unwell, all the way to the time that they are unwell. The skills that you learn in mental health first aid helps in here. And if we're helping in here and we're doing this work, it then will trickle down and result in assisting in removing some of the stigma. So we do mental health first aid, and we explain about, we explain what mental illnesses and disorders are. We're educating, we're informing, we're removing some of the ignorance and helping to remove and reduce some of the stigma. Any questions on the spectrum of mental health interventions, or just people's individual state of mental health? And about 10 more minutes, I'm gonna plow through 10 more minutes. And I was worried I didn't have enough content. Okay. I am going to see here and here. Okay, so early intervention, mental health first aid is part of early intervention, and early intervention is so important. And let me just give you some, Okay, so a lot of times mental health illnesses and disorders, they start in adolescence, and they're ignored, they're not noticed, they're not treated. So there's no early intervention. And then by the time the person is an adult, usually around age 27, they really start to present. So it's really, really important to have some early intervention. And that's why there's a youth and an adolescent mental health first aid, because we want to show professionals who are dealing with those age groups how to notice different things and how to then intervene. So without early intervention, poor long-term functioning, increased risk of depression and suicide, slower psychological matriculation and delay in assuming adult responsibility. So all these things can happen if it's not recognized and starting some treatment or some intervention early on. Where does diagnosis fall in? That's exactly right. So who was that? Patty, where does this diagnosis fall in? Okay, that was Patty. Okay, yeah. So when we notice when the signs and symptoms of different disorders are now presenting, we don't diagnose as mental health first aiders. We notice the signs and symptoms, And then we have to get the person, remember, mental health first aid is that gap, getting the person to the professional who can actually do a diagnosis and can start a treatment. So it is noticing the signs and symptoms, and those signs and symptoms can be psychological, they can be physical, they can be behavioral. Based on what individuals are doing, you know that you will be able to equate those to certain illnesses. And as you're supporting them through algae, and we'll talk about algae, as you're supporting them through algae, which is the action step for mental health first aid, getting them to the professional who will do the diagnosis. Because as mental health first aiders, we are not trained to diagnose. Now, some of the individuals who are mental health first aiders are actually professionals in the mental health field, and they can diagnose. Patty, does that answer your question? Just chime in and let me know. Now I'll go back. Okay, so why mental health first aid? So one of the main reasons for mental health first aid is, as I said, we want to, it's part of an early intervention. It's part of an early treatment, is a way to get people to treatment early. Patty says it was okay. I just, you know what? I figured it was from somebody else, and you were just typing it into the chat, Patty. But hopefully, Kosi, I think it's Kosi. Hopefully, Kosi, that it was from someone else. So hopefully that helps in regards to your question in regards to diagnosis. So why we want to use mental health first aid? One reason is because we're professionals and we want to use interventions that are evidence-based. And there has been evidence that has been tested, and there have been trials, and individuals who have experienced mental illnesses have used a certain protocol. Others have used the mental health first aid protocol, and then they've compared the data, and the results show that the individuals who went through the mental health first aid or was taken through some of the action steps were able to get to help and get to recovery. So it's evidence-based. That's one reason why we want to use mental health first aid. But mental health problems are common. That's what we talked about. In any given year, we can have up to 18% of the adults in the US experiencing anxiety, and not just feeling anxious, but having anxiety that can lead to panic attacks. And we know that those are disabling. So we want to use mental health first aid because mental health problems are common. Because of the stigma that's associated with mental health problems, we can use mental health first aid to bring about awareness and educate people and to reduce the stigma. Many people are not informed, so that's what we're doing. We're informing them about mental health illnesses through mental health first aid. Professional help is not always on hand. It isn't. So we are going to implement some steps to help the person until we can get them to help, or till we can get help to them. Just like CPR and first aid for a physical illness, mental health first aid is for mental illnesses. People often do not know how to respond. When you see somebody experiencing a mental illness, sometimes we don't. We're bystanders, and we might step right over the person and keep it moving because we don't know what to do. Mental health first aid helps us to know some things to do if we notice that somebody is experiencing it, or it's been presented to us that somebody's experiencing mental health illnesses and disorders. And also, as we said, because of stigma, just for whatever reason, people with mental health problems often do not seek help. And sometimes they do not seek help, sometimes because they don't know they have a mental health problem. They're still in pre-contemplation. Sometimes they know they have a mental health problem. They just don't know how to seek help. So sometimes it's up to us to be the ones to initiate that. So that's why mental health first aid. I got 6 minutes. I'm going to plow right through. Okay. So Rhonda, I think that was you who asked me, who put in the comments about the action plan. So that's where we are now. We are at ALGE. ALGE is the mental health first aid action plan. ALGE is the acronym, ALGEE. So the action plan is, A stands for assess. We first assess for the risk of suicide or harm. That is a very real situation for a lot of individuals who are experiencing mental health illnesses and disorders. And so we have to assess for suicide or harm. Sometimes it's about looking around, the person's not talking, noticing things on the person's body. Sometimes it is simply saying, are you considering harming yourself? or someone else. And if you notice, we call it a hotline, or if you call to get some help for a psychological or mental issue, that's one of the things that the screener asks you on the telephone. Are you thinking about, have you thought about harming yourself? So in mental health first aid, that's one of the first things we want to do. Then another step is to listen non-judgmentally. We listen, 2 ears, 1 mouth. We want to hear, allow them to tell us and explain to us what's going on. So we want to listen non-judgmentally. And in doing that, there's probably some nonverbal communication skills that we have to put into action. Give reassurance and information. So you are in your action step when you're doing your mental health first aid, you are assuring them, that what they're feeling, what they're experiencing is real. We want to make sure that they know, and we want to give them some autonomy in the situation. And then we want to give them information as to what's, ways that they can be helped. And we'll talk about that in a second, or just information about what they're saying to us. So sometimes it's about how we paraphrase or summarize what they're saying to us. Encouraging appropriate professional help. So when we see that they're experiencing certain things, they're telling us that they're experiencing certain things, we need to encourage appropriate professional help, because we can't diagnose, right? We're not that professional, but we want to encourage professional help we want to encourage help from the professionals. We also want to encourage self-help from others and support groups. So some of the self-help is not from the professionals, things that the individual who's experiencing the illness can do for themselves. 4 minutes. Okay. So assess for suicidal harm. Again, we are basically we're asking them, have they had suicidal thoughts? One of the myths here is that if you ask somebody this, you put that thought into their head, but you're not. If that thought is in their head, they're going to do it. If that thought is not in their head, they're not going to do it. So you're not making them, you're not pushing them. When I took mental health first aid, this was the hardest thing. I never thought I was going to be able to get through this step. I thought I was never going to be able to ask this question, but I understand now that it's one of the first, why it's so important to do. Listening non-judgmentally. Here, and I say this is, it's all about, we don't want to stigmatize people, right? And we want to be very empathetic as we're talking to them, as we're listening to them. And as I said, a lot of times our nonverbal communication skills, we want to be attentive. We want to look at them, but comfortably. We want to be staring at them like they got 2 heads. And we want to have our open body posture. So we're not there here. I don't know if you can see me, because I can't see me, but we want to be, open, hands to our side. And even when I say that, okay, you want to be seated, and next to the person would be really good. And you don't want to be fidgety and like you're nervous about dealing with them. And in this instance, you also want to be in a position where you are still keeping yourself safe, putting yourself in a good position. So if something was to happen, you could exit without being harmed. So I always make certain that I'm near the exit or the door, and that the person is not would be blocking my way if I needed to get out for some reason. Giving reassurance and information. What that looks like is treating a person with dignity and respect. We're doing that. We're not stigmatizing a person, right? We're understanding the symptoms and an expression of distress or part of it. And so it's all about the symptoms. We want to talk to them about the symptoms that they're having, right? Make sure that there's some realistic expectations. We don't want to say that tomorrow it's going to be all over. No, because we can't say that. We want to, you go through treatment, you will recover. It may not happen immediately, but it can happen. Hope for recovery. They don't have to stay where they are. They can move through the spectrum and get to be better, get to where they were before, and provide practical help. We don't want to do things for them. We want to make sure that they're doing for themselves, and we're going to guide them through doing things themselves. Credible information, very important. We are not offering any kind of pie in the sky treatment, recovery. There's no miracle pill. Credible information, evidence-based information is what we want to provide when we're giving out our information. Encouraging appropriate professional help. Here, types of professionals that you can encourage them to see or try to get to them would be doctors. They can reach their primary care physician. Good place to start. Psychiatrists, psychologists, social workers, counselors, other mental health professionals, and certified peer specialists. Okay, chat, is that my 2-minute warning? So excited. So we need to devote more time to this at the next conference doing leadership. All right. Thank you so much. Awesome. Thank you, Dr. Rana. That makes me feel really good. We hopefully at the next conference we can thank you. We can do a whole training, the full training, and have everybody who finishes get their certificate. So I would love to do that. Thank you, thank you, thank you, thank you, thank you. Awesome. And then we have some folks who are certified. This is wonderful. I'm gonna get through these last through. Oh man, my time is up. Okay, if kids, you please give me just 2 minutes to finish out. Is that okay? Let's have a few more slides. 2 minutes to finish out. Okay, so we have these professionals, and then the professionals are. We have these professionals, and these professionals, 2 minutes, okay. And we have these professionals, and these professionals will provide this, will provide services. And the services can be talk therapies, they can be medications, and there can be other type of help that the professionals will provide. Thank you. Awesome. I'm glad you enjoyed it. Thank you. Encouraging self-help. Things like exercising, meditation, relaxation, peer groups, support groups, self-help books. So all of those things can help the person to start taking steps themselves to improve their mental health status, and then working with their family and their friends. And my time up, Patty? Awesome. Thank you very much. Oh, thank you. I'm glad you enjoyed it. Thank you. I was going to do a reflection. I can't do a reflection because my time is up, but I want you to think about it. Of those action steps, which ones would be challenging for you and which ones would be manageable? And then Rhonda, here is the koala bear, Algae, which is a mascot for Mental Health First Aid that you mentioned earlier. But that is what I have for you. So we went through the what is mental health? Yep. So we talked about mental health and the challenges on adults' well-being. We talked about the correlation between stigma and mental health. We described mental health first aid, and we talked about the mental health action plan. So I am hoping that was helpful. That was interesting. It was interactive. It has been my honor to present this to this wonderful group here at the International Conference on Stigma. And I hope that, as Dr. Rana said, next year we can actually take it to the next level and actually do the full training and have folks certified in it. So thank you for indulging me for the last hour and a half or so. Here's my contact information. If anybody, you can snap a picture of this. If you need to reach out to me, please feel free to. I'd love to chat with you some more. Thank you. Thank you, Patty. Awesome. Thank you. Thank you. Yep. So someone asked for the Rhonda. Here's my information right here. Snap a picture. Please reach out. Thank you. Thank you, Dr. Rhonda. Thank you.